Good afternoon, ladies and gentlemen, Mr. Chairman. Thank you very much for the invitation. What I would like to do is to try to really quantify these benefits and harms instead of coming up with general statements of whether it does or does not outweigh the benefits. So the rationale for screening on PSA is clear-cut. It is an increasing public health problem. In the past, at relatively late stage, prostate cancer was diagnosed, so 1/4 or so already had distant metastasis, and we really know PSA is the exception to the rule. It is a very exceptional biomarker. So here gives you the idea about the expenditures on cancer care in the US in 2010, and indeed on the top is female breast, colorectal, and on the third place is lymphoma, lung, and prostate. And yes, if we look at the age-adjusted incidence of cancer by time since 1975 till 2008, only this enormous peak stands out, only due to prostate cancer incidence and PSA testing starting at the end of the 80s. This is a graph from the world, sorry, not from Europe, but on the top it is the whole world, and prostate, highest incidence of cancer is here in the US, many places in Europe, Australia, etc. And on the bottom it is mortality given the disease, and then it's prostate mortality is the same colors here over here, but lung, of course, is all the blue parts. So what is the idea about screening? You try to detect and treat a disease or a condition or an abnormality at a stage in which no symptoms have yet appeared. And the idea is to halt or delay the adverse progression of the disease and improve public health. So normally you have some symptoms, a diagnosis a little bit later, and you start treatment. And unfortunately, there are still some serious consequences of the disease, here shown in red. But for a long period of time, with some diseases and some tests, the disease can already be screen detectable. And of course, in prostate cancer and PSA, this is really a long time frame. And you hope with the early detection that finally here on the right-hand side, the serious consequences may diminish or you have increased life expectancy. So I will show you some details of the European randomized study of screening for prostate cancer. These are the 8 countries that were involved, and they were ranked by the amount of people enrolled. Finland being the largest center, Rotterdam, the Netherlands, the second, Sweden, the third. And this is the second mortality reduction published in the New England Journal in 2012 by the PI Fritz Schröder as first author. And here you see by time the cumulative hazard of dying from prostate cancer in the control group versus the screening group. It takes quite some time, somewhere up to year 7 or so, before the lines diverge. This means in an intention to treat analysis something in the order of 20%. It means a true screening effect in the order of 30% if you adjust for compliance and contamination. So there is a randomized controlled trial, but then still, why would we have to model, which I will show you a bit later after these slides, why would you still want to model the natural history of the disease and what screening can do? Why? Because all trials have just one fixed design and enroll specific subgroups. So you basically get just one answer to one specific question. Trials have a relatively short follow-up duration, and you have to have modeling to estimate this blue period, the screen detectable preclinical period, and the sensitivity of the test. Then you can try at least to estimate the impact of screening in different settings, in different ages, in different intervals, etc., etc. And very good to realize that modeling often does not, modeling often provides the estimates on overdiagnosis, which usually you cannot capture in a trial at a certain given short follow-up period. You have to go beyond the 5, 6, 7, 10 years time period. And that's exactly what we have been doing. This is a picture in which basically the 2 important issues are depicted. So normally there is birth, onset of the disease. Cancer may already be detectable by a screening test, but the cancer is diagnosed clinically at this point in time. If you now add a screening test to this lifetime, then it may be earlier detection, cancer diagnosed, screen detected. The lead time is the earlier time of the diagnosis now, and you hope that at the end here on the right-hand side, the effect would be life years gained and prostate cancer death averted. We know at the same time, given this enormous long screen detectable preclinical period and lead time, that the crucial thing is overdiagnosis. There may be an onset, cancer may be detectable at screening from this point in time already, but in this specific life history, actually the cancer is not diagnosed clinically because of death from other causes. So if you now add the screening test to it, you do get the cancer diagnosis as a screen detected case, but it would otherwise never have been diagnosed clinically due to comorbidity, etc., etc. And the longer this lead time, the longer this screen detectable preclinical period, the more chances you will have that you will now find cancers. They are there, the pathologist says it's cancer, but it would otherwise never have been clinically diagnosed. So these are the two elements that are crucial, and it's therefore crucial to try to quantify this as best as possible. So this extremely early detection can be favorable. At the other side, it is its pitfall too. So as shown and already mentioned before, this mean lead time, the advancement of screening, of the diagnosis by screening, can be maybe something in the order of 11 or 12 years. That is really huge compared to many other cancer sites. It would mean that up to 50% of men with screen-detected prostate cancer would never have been diagnosed in the absence of screening tests, and it means long-lasting side effects of treatment. In fact, just getting the diagnosis of cancer, of course, negatively has a negative impact on quality of life. It has been nicely shown by this paper by Ida Korfag in the European Journal of Cancer, in which there are, on the y-axis, it's an average score on the quality of life measures, 3 different measures actually. And here it is a score 1 month after diagnosis. Normally you start doing quality of life research after diagnosis and you see what happens, and basically this is 1 month after diagnosis, this is 7 months after diagnosis, and roughly it either goes basically towards a better quality of life or roughly the same thing. But mostly you don't have the information before the diagnosis. In this case, we do have that 2 months before diagnosis. Why? We sent about 3,000 questionnaires to men enrolled in the European trial, and out of these 3,000, some 52 were diagnosed with cancer later on. So we can now look at the quality of life measurements of these 52 before diagnosis. And what we basically see is that just getting the diagnosis of cancer leads to a reduction in quality of life, which of course, if you see patients, you know this is the thing that will happen. So if we're going to screening, this is a guideline, a recent guideline from the American College of Physicians, and what they say is the ACP recommends that clinicians inform men between the ages of 50 and 69 about the limited potential benefits and the substantial harms of screening for prostate cancer. That can be true, but you have to try and quantify that. So what are the harms and benefits? Benefits is prostate cancer mortality reduction, life years gained, and not to forget, a reduction in advanced disease for those men not dying from prostate cancer anymore. What are the harms? Overdiagnosis, overtreatment, and important, lead time years, the amount of time that you know you have a prostate cancer. So is that overdiagnosis and overtreatment a real issue? It's an enormous issue. These are three graphs from the incidence of prostate cancer in the US by time, and 3 models, the University of Michigan, the MISCOM model from our institute in Erasmus, and Fred Hutchinson model, try to estimate whether we can validate the incidence in the US and how much of that, of the amount of cancers being diagnosed since introduction of screening has been overdiagnosed. And it gives you some numbers in the order of 23% to 42% of screen detected cases is probably overdiagnosed in the US. This is what we try to do. We try to make a model of the natural history of the disease. So it goes from no prostate cancer, it goes to a T1 Gleason score below 7, to a T2 Gleason below 7 or 2, 3 plus, and possibly get clinically diagnosis in one of these stages. We also have a progression going from Gleason under 7 to Gleason is 7 or Gleason above 7. Given this enormous long duration of screen detectable preclinical period, we do think there is progression actually through grades. The point is, you have to get the best estimate of this duration and the sensitivity of the test. So with the sensitivity of the test, it's now, for instance, possible to get a screen-detected case, T2 Gleason 7 or so, and otherwise it would, for instance, have been diagnosed clinically at some point or clinically at a later point. This is what you try to estimate as best as possible. And people sometimes look at these graphs and then say, that is not possible. How can you do it, all these transitions? It is not that difficult. It's about transition probabilities and the duration of the stages and test sensitivities. But the point is, if you have a lot of data from screening trials, you can try to make the best estimate. For instance, if you have a test and you say, okay, I start off with a sensitivity of, for instance, 60% in this model, if you assume that to be too low, it basically means that the model would expect more prostate cancers to occur in the interval between two screens than observed. So if you have data about these interval cancer cases, you can try to fit it as best as possible, and you have to assume sensitivity must have been higher than that, because my number of interval cancers is less. On the other hand, if that duration in this preclinical detectable period is assumed too short in your model, then the model would expect less prostate cancers to be detected at screening than observed. So again, if we have a certain amount of cases being detected at different rounds, it gives you a clear-cut idea about this duration in the preclinical stages. So such a model just tries to reproduce the observed data as good as possible. Well, that's what we actually did. We really tried to quantify the harms and benefits, and we were very happy, of course, that it has been published last year in New England, and I'll try to explain that a little bit to you. So we tried to use a lot of data from the European trial on side effects. This, for instance, is table 2. I'm not going into the details, but for instance, it shows you from Göteborg and Rotterdam area. It gives you, for instance, the daily urinary leakage after prostatectomy or radiation therapy. So you see, for instance, preoperatively, it was only 2%. It goes up to 16% after 6 months, or 52 or 6% after 2 months. But it is especially also here sexually active and erectile dysfunction that goes from something in the order of 31% preoperatively to 88% after treatment, and it remains there for a long, long period of time. So there are clear-cut data, and this is just from 2 centers in the European trial, but of course there's a lot of data on that in the US, worldwide, etc. We try to use that. But the big point is that it's just one factor involved. So here on the left side, you basically see all the important aspects that you have to introduce when you do want to make an estimate of harms and benefits. It's the screening, it's the diagnostic phase, it's getting the diagnosis, it's the primary treatment, but most important here, it's the post-recovery period. You may have important side effects of treatment in the first place, in the first year, but in year 4, 5, 6, 7 or 8, the important question is still how much impact on quality of life does this have? On the favorable side, of course, there is palliative treatment, terminal illnesses that will be reduced if your screening program is effective. So based on the literature, we try to come up with the best utility, so that's a sort of impact on quality of life that has been published in literature. So it means, for instance, palliative therapy, if you will be preventive of dying from disease and having palliative therapy, this will have probably an impact of about 40% on your quality of life for instance, 30 months. But again, here you see it's a post-recovery period that has a long time frame that is really crucial what this utility measure should be. And that's not easy. So again, this is a table from the New England. Again, I will not go into details, just to show you how it works, and so you can, if you reread it once, you think, oh, that's what they did. So for instance, if you take your biopsy, it says without a screening program in 1,000 men between the ages of 55 and 69, we probably have something like 313 biopsies. In a screening program, we would have 605 biopsies. So the difference is almost 300 additional biopsies. 300 additional biopsies, we think, has an impact for instance, 5 weeks or so, or a month. So the 300 times the month is something like 17 life years. In these 17 life years, we think, going back to the front here on the left, that those 17 life years, you will have a reduction in quality of life in the order of 10%. So 17 times 10% is minus 1.7 quality life adjusted year that you have to diminish from your benefits. That is what this total table says. And if you do that, this is then the final result. If you have 1,000 men, screening ages 55, 69 at 1 year intervals, you will gain approximately 73 life years gained. These 1,000 men will gain 73 life years. But if you adjust for all these quality of life measures on the left-hand side, so this is basically, again, the amount of diagnosis being made, the amount of quality of life being reduced, times the amount of time, it has a reduction of 0.7, but on the total, you see here on the end side, it is a correction of almost 17 life years gained. So it means if you screen 1,000 men, ages 55, 69 at 1 year intervals, we think you will have 9 fewer deaths from prostate cancer. You will have 14 fewer men receiving palliative care. They will, on the whole, these 1,000 men will gain 73 life years gained, but correcting for quality of life in the order of 56%. That actually means that for a man not dying of prostate cancer anymore, he will gain in the order of 8.4 life years gained. If you adjust this for this 23% correction, he will basically gain something like 6.5, let's say, healthy life years gained. And the big argument, of course, is, well, is this a lot? Is this too few to start a program, yes or no? And that's, of course, a difficult judgment. So the screening, the US Preventive Services Task Force basically said, okay, the US trial did not demonstrate any reduction. The European trial showed 1 death prevented per 1,000 men. And so it's something like between 0 and 1 prostate cancer deaths avoided if you have 1,000 men screened. As I have shown you now and show you again, I guess, both numbers I think are really wrong. The 0 is from the POCO trial, but that was a heavily underpowered trial, as we know now, because of the contamination rate and the very, very low biopsy rate. The one from the POCO, from the European trial, is the point estimate at 11 years of follow-up, but you have to include longer follow-up after the 7 or 10 or 11 years. And that is actually what we did, and that's why we come up basically on the 9 fewer deaths with such a modeling estimate. So there is the new AUA guideline, just came out this month, I think a very important change. They say the new guideline is significantly different, and I think it's true. And it provides rating and interpretation of evidence based on randomized controlled trials with modeled and population data as supporting evidence. So that, I think, is really a change. The highest quality evidence for screening benefit was in men aged 55-69, screened at 2 to 4 year intervals. That's basically the European trial. And data demonstrated that 1 man per 1,000 screened men will avert a prostate cancer death over a decade. However, over a lifetime, this benefit could be much greater. And that is exactly the point that I would like to make. This 1 per 1,000 is at a certain point in time in the European trial, but we think that if you take into account the lifetime risk and the lifetime risk for death from prostate cancer, it's in the order of 9 per 1,000. So that's again this one. Sorry, I go back, sorry for that. So what do the AUA guidelines now say? Routine screening in men aged 40 to 55 at average risk not recommended. 55-69, a man has to weigh the benefits with the harms. And again, here they say that 1 for every 1,000 men. They do say a routine screening interval of 2 years or more may be preferred over annual screening, but please do not do routine PSA screening in men over age 70 or any men with less than 10 to 15 years life expectancy. So I want to show you a couple of 3 slides or so on treating. The point being that if you now do screen, you will have screen detected cases with prostate cancer, and they actually have the option to treat the cancer immediately or postpone or refrain from treatment. And the same thing we did now is we try to predict harms and benefits of immediate treatment after screen detection versus treatment at a later stage. And again, you have to balance the 2 things. You basically have to balance overdiagnosis and overtreatment or overtreatment versus the enormous amount of side effects. So again, you have to sort of look at the benefits like life years gained or prostate cancer deaths averted and compare those to actually either expected life years lost without the potential side effects of curative treatment, so overdiagnosis, lead time and overdiagnosis. And you can do that by Gleason score, T-stage, etc. And I just wanted to mention that it is in press in British Journal of Cancer, so that you get a bit of an idea if you read that in the next couple of months or so. Again, here to show you age 70 to 74, on the x-axis is the amount of overdiagnosis, and on the y-axis is prostate cancer deaths avoided. So you see for ages 70-74, they are basically all in this gray area. A lot of percentage of the overdiagnosis compared to on the y-axis, some chance of avoiding prostate cancer death. So in the order of up to maybe 10% or so for this specific prostate cancer, but in the most it's really, really, really limited, whereas the amount of overdiagnosis is enormous. This is 70-74. This is 55-59. Again, there is overdiagnosis, up to even 30% for this category, but this is much more in a lower range, whereas on the y-axis you do see that the amount of prostate cancer deaths avoided is really important. And basically you can do the same thing for different ages, and you see the sort of changing in which color line these treatments are. We did the same for overdiagnosis versus prostate cancer deaths avoided, or you can do lead time years and life years gained. So again here on the x-axis it's mean lead time years, so it's enormous the amount of years that you then know you have prostate cancer or you get retreated or you have side effects, and on the y-axis it's the number of mean life years gained. Again, rather favorable for the young ages, very, very unfavorable for 70-74 and maybe even for 65-69. So conclusions on treatment is you have to include lead time, you have to include the amount of time that you know you have prostate cancer and side effects of treatment, but it seems that men aged 55-59 with moderate risk are the best candidates for immediate curative treatment. This is very unfavorable for men aged 70-74, regardless of Gleason score and clinical stage. So what will be the future? My last two slides. It is crucial to incorporate the active surveillance. It's crucial to incorporate more individualized protocols, try to use decision aids and really incorporate in these decision aids the estimated long-term benefits and harms. The next step would be to really estimate cost effectiveness of screen scenarios, and probably it will mean very limited testing between a rather narrow age range. But with that, I do really think we can change public health policy and healthcare towards a better harm-benefits ratio for a substantial number of men. So, although I have always been very reluctant before we really had the final results from the trials and we really incorporated these quality of life estimates, to some extent PSA testing is promising, but it's crucial to quantify these unfavorable side effects, and it's true then that the benefits are probably diminished with about 20% when you take into account quality of life. To prevent one prostate cancer death, it's more in the order of 100 men that need to be screened. That is what you get when you really try to make the best estimate, including future benefits and harms. Active surveillance is really crucial to try and decrease the amount of overdiagnosis, and it's clear-cut. Please do not screen above the age of 70. You will basically, for the population as a whole, you will gain less quality of life years gained than if you would have stopped at the age of 70, and that is simply now consistent with the new AUA guidelines. Thank you very much.